Today we're focusing on multiple organ dysfunction syndrome, also called MODS. MODS is altered organ function in critically ill patients that requires medical intervention to keep the organs working. Think of it as another phase in the progression of shock states. It's hard to pin down exactly how often MODS occurs because it develops in patients with acute illnesses that already compromise tissue perfusion. But we do know this: if one organ system fails, mortality is about 20%. If more than 4 organs fail, mortality jumps to 60% or higher. The exact mechanism isn't fully understood, but MODS is most often seen in sepsis, when tissue perfusion can't be restored effectively. Much of the damage happens at the cellular level, so it can't always be directly measured. MODS usually develops late in the continuum of septic shock, once compensatory mechanisms are exhausted. The presentation is insidious. That means slow and sneaky. First, tissues become hypoperfused on both a microcellular and macrocellular level. Eventually, organs begin to fail, requiring mechanical and pharmacologic support. MODS often begins with the lungs, followed by instability in the cardiovascular system, then failure of the liver, gastrointestinal tract, kidneys, immune system, and nervous system. Clinical manifestations. We can't predict MODS with certainty, but we do have clinical scoring systems that help assess severity and risk. These include APACHE, Acute Physiology and Chronic Health Evaluation; SAPS, Simplified Acute Physiology Score; PIRO, Predisposing Factors, the infection, the host response, and organ dysfunction; and the SOFA score, Sequential Organ Failure Assessment risk factors that increase the chance of MODS include advanced age, malnutrition, and coexisting diseases. The classic pattern usually begins with the lungs: progressive shortness of breath, acute lung injury, or acute respiratory distress syndrome. Mechanical ventilation is often required. Hemodynamically, the patient may need increasing IV fluids and vasoactive agents to support blood pressure and cardiac output. Signs of a hypermetabolic state appear: hyperglycemia, meaning high blood glucose; hyperlactic acidemia, meaning too much lactic acid; increased blood urea nitrogen, or BUN. The metabolic rate may climb to 1.5 to 2 times the basal rate. The body responds with severe muscle breakdown to meet the increased energy demand. After about 7 to 10 days, we often see hepatic dysfunction, rising bilirubin, abnormal liver function tests; renal dysfunction, elevated creatinine, reduced or absent urine output; hematologic dysfunction, poor clotting, immunocompromise, and bleeding risk; cardiovascular collapse, unresponsive to medications; neurologic decline, progressing to coma. The bottom line: the more organs that fail, the worse the outcome. Medical management. The best treatment for MODS is prevention. Older adults are at greater risk because of reduced physiologic reserve and immune compromise. Early recognition of subtle signs of infection, such as confusion or low-grade fever, is essential. If MODS develops, the treatment goals are: 1. Control the initiating event, like infection or trauma. 2. Promote adequate organ perfusion. 3. Provide nutritional support. 4. Maximize patient comfort. Nursing management. Nursing care in MODS looks similar to care in other shock states. The priorities are: support the patient, monitor for signs of organ perfusion and dysfunction, work with the team to halt the primary insult. Family support is also crucial. End-of-life discussions may be needed to align supportive therapies with the patient's wishes. Promoting communication. Nurses play a key role in communication. This means ensuring that patients who survive MODS understand the long rehabilitation process, especially because severe muscle breakdown slows recovery. Building trust through honest conversations about goals and expectations. Promoting home, community-based, and transitional care. Patients who survive shock or sepsis may need long-term rehabilitation. Education for the patient and family should cover prevention of future episodes, monitoring for complications, treatments like IV therapy, nutrition, skincare, and gradual increases in activity. Many patients will require long-term care or rehab facilities after discharge. Others may transition to home health or community-based care. We also need to recognize post-intensive care syndrome, or PICS. This includes ongoing physical, cognitive, and mental health impairments that persist long after the acute illness. Nursing interventions to prevent PICS during critical illness include early mobilization, careful delirium assessment and management, promoting adequate sleep, helping liberate the patient from the ventilator as early as possible. Final takeaway: MODS is the culmination of shock and sepsis, where multiple organs fail due to ongoing hypoperfusion. Prevention and early recognition are key. Once MODS sets in, outcomes worsen with each additional failing organ. Nursing care focuses on support, monitoring, communication, and education for both patients and families. Survival often depends not just on medical treatment, but on compassionate, coordinated care during and after critical illness.